हेल्थ प्लस प्रोग्राम में आप सबका स्वागत है। आज हम आपसे बात करने जा रहे हैं एक रीजनल कॉन्फ्रेंस की, जो कि पिछले दिनी लुधियाना में 10 और 11 सितंबर को हुई। ये कॉन्फ्रेंस इंडियन एसोसिएशन ऑफ गायनेकोलॉजिकल एंडोस्कोपिस्ट के द्वारा की गई, जिसका विषय था एनहांसिंग गायनी एंडोस्कोपिक स्किल्स। ये कॉन्फ्रेंस होटल निर्वाणा लुधियाना में हुई। दूर दूर से डॉक्टरों ने इस कॉन्फ्रेंस में शिरकत की और अपने विचार लोगों के साथ साझा किए। हमारी टीम ने डॉक्टर जीनी गिर्ण जी से बातचीत की, जिन्होंने हमें इस रीजनल कॉन्फ्रेंस के बारे में विस्तृत जानकारी दी। आइए डालते हैं नजर इस कॉन्फ्रेंस की कुछ झलकियों पर।
Because of the toxicity of the glycine and it's a hypoosmolar solution, so there is an hyponatremia which is difficult to treat. So we have switched over to the bipolar saline resectoscope, where saline is used as a distension media, and there is a only complication which we have to face is a fluid overload. So input, inflow and outflow has to be maintained, and one has to calculate what the fluid has gone in and what has come out. So no speculum is used, no valsalum is required, no dilatation, no pain. So we go inside, the pressure, intrauterine pressure is less than 45 millimeter. This is a bipolar saline needle. So you just cut the polyp in 2 or 3 pieces, fibroid polyp, and then that detaches from the base. This was a postmenopausal bleeding patient with a mass inside, and it turned out to be an adenocarcinoma. So Professor Stefano Bitocchi from Bari, Italy, has changed the concept that internal os is not a circular but a transverse oval, and design an oval sheath which is helpful in the creating an office hysteroscopic procedure. Sometimes we encounter a very difficult and challenging to negotiate the internal os, but you just go at the internal os, wait for some time, let the fluid go inside the uterine cavity. Once the cavity is distended, the internal os opens automatically. So just give some time at the internal os, let the fluid go inside the uterine cavity, let the uterine cavity distend, and the gates are open for you to walk inside the uterine cavity.
The publication is device PSAT's visual vasopressor injection needle (VVIN), an internationally patented and published device for enhancing safety in laparoscopic myomectomy. Device shoeless knot, a method for reversible ligation of uterine artery at its origin in patients undergoing myomectomy desirous of future fertility. His awards achievements are the Make in India Healthcare Innovation Award 2018 by Professor Rajendra P. Prasad Gupta, Advisor to Health Minister, Government of India. May I welcome you, sir?
Topics rolled into one, so I'm going to try and do justice to both of these topics. Entire presentation is only surgical videos, so if you feel the need, please stop me in between. I can answer questions, or we can take questions at the end also. Before starting with hysteroscopic septal incision, there are few things that we need to understand before the surgery started. Generally, it is a little diagnostic dilemma for everybody to understand how exactly to diagnose a uterine septum. Larger grades of uterine septum are always confused with bicornuate uterus, and smaller grades of uterine septum are always confused with arcuate uterus, so we do not know whether or not we should be operating in the first place. So in order to cut the whole diagnostic dilemma short, one single diagnostic tool which is of utmost importance is 3D ultrasound, and what we look at is simply this coronal view, and you look at the interosteal line. Once you get the interosteal line joining the two ostia, look at how much of depth of septum is there below the interosteal line and how much is above the interosteal line. If this distance number 2 is more than 50% of distance number 1, then the patient is said to have a uterine septum. This is the present accepted classification and definition of uterine septum which we use in day-to-day practice. The second thing that you have to see is whether or not there is a dip at the serosal fundus. At the fundus here, if there is a dip like this, that means this is a case of a bicornuate uterus or a bicorporeal septate uterus. There is a classification entirely given, but be sure to differentiate between a septate, bicornuate and an arcuate uterus before starting the surgery. This cannot be done intraoperatively. So with that, we will start our surgical video. First, I think we are going to be dealing with hysteroscopic septal resection, and it would be good to say that septal resection itself is a kind of misnomer, because we do not resect the septum now. Although there are studies which suggest that you can remove the septum en bloc, most of us are only incising the septum. We just take an incision on the septum. The choice of instrument is always the cold hysteroscopic scissor. There are several reasons why a hysteroscopic scissor is preferred over a resectoscope. We are going to come to that. But let us first look at the technique. The technique is fairly simple. You go in with the hysteroscope, you see a elevation between or a ridge between the two ostia, that is the uterine septum, and you start cutting the uterine septum with the hysteroscopic scissor gradually from one direction to the other. So you go from left to right, right to left, and so on. At least in the initial years of practice, when you are new to doing hysteroscopy, do not try to cut the entire depth of the septum all at once. For example, what I am doing here now. Do not try to make it to this much level all at once, because sometimes if you lose your panoramic view, you may not get an idea of how deep you are supposed to cut. How is your guide going to be? That means what are you going to use to actually do the surgery completely? Your guide or your end point is going to be the tubal ostium. So an approximate depth of cut where the tubal ostia are not separated by any ridge that comes down in between is your end point of surgery.
Induced by surgical trauma. Trauma which could be a curettage or any surgery which leads to the involving the uterus. So now the most important dilemma occurs with the diagnosis and the treatment for these Asherman syndrome. Majority of the cases we can diagnose them clinically. The patient who has undergone previous surgery or previous curettage and now she presents with infertility or menstrual disturbances. If the woman has come with amenorrhea and she has a previous uterine trauma, and if you have given the estrogen also, progesterone, and she does not bleed, it is almost always an end organ defect, and that is the Asherman syndrome, and be the alternative. MRI should not be used for the diagnosis of intrauterine adhesions outside the clinical research. Now coming to the ultrasound. Now in the normal cases we usually find a normal triple line endometrium which is seen. But if the patient is having the Asherman syndrome, very important to differentiate these filling defects from the artifact. So if we ask the patient to strain or change the position, then these defects will not change. But if it is an artifact, certainly it will change or may disappear.
This is also patient with previous to cesarean section where the uterus is placed at the anterotal wall along with the omentum. So we have to keep on dissecting into the proper plane. Here also you can see after the detachment of the omentum, the uterus is adherent and start from the lateral angle. Again here you have to go into the either in one plane above the peritoneum, or you can dissect into the muscle of the uterus. Here the vaginal assistant with the help of the manipulator try to retrode the uterus. So the structures they are under stretch, and then you can find them plane. Many times you have to go into the myometrium or in the above the peritoneum into the abdominal wall, and gradually you dissect the uterus. Here you have to be very careful because the bladder may be attached to the fundus.
Reduce the size of your fibroids, make the surgery a little smaller and faster.
And decrease the operative time.
Yes. And secondly, as ma'am pointed out, it is the young woman, it is the estrogens and the progesterone, the sex hormones which are causing the inhibition of the sodium potassium ATPase pump. There's more reabsorption. So once you cut off these with the GNRH analogs, that fluid tendency to have a fluid overload will also be reduced. She'll be like an older woman for some time. You have to avoid it. And how much concentration? How would you do it?
It is 8 ml of 0.05 units per ml. So it has to be diluted.
Yes. And 0.5 or lesser, not more than that. That is the other.
Yes. And it prevents the fluid absorption. Absolutely.
Absolutely. So this is one thing which
the reflux mechanism with the wrapping of the reducer muscle over the lower end of the ureter so that there is no reflux in the post-operative period. Here the catheter is kept for 14 days and the digestion was kept for 6 weeks and it can be removed. So when you are dealing with challenging situation, you need to have perseverance, out-of-box thinking, and ultimately my goal is not to be better than anybody else but myself. So thank you so much for your question.
Do you first try by posterior colpotomy?
Yeah, that is the
Or
standard.
do you try to be open or
No, there is no need to open the patient. Do posterior colpotomy. You can use slight GA to the patient. Do posterior colpotomy. You can target the stitch with one of the artery versus
Yes, just cut it.
identify the suture and cut with the scissor. Don't remove the suture. Let it be there. Just give one cut posteriorly and the cervix is open.
We had such a wonderful show. I heard that the workshop was a great success, and the entire team has been working very hard for many weeks now. We've been having our Zoom meetings, and we've been really kind of approach that they, and of course it's a wonderful event which has come through, and I'm sure it will be remembered for many months. My first purpose of starting this presentation, or rather when we take up any patient, is premium normal share, which means please do no harm. That is a very, very important thing. I think Dr. Pandit Palaskar showed us, Pandit Palaskar showed us some wonderful surgeries, but I'm sure he hasn't started that in one day. It's been a long journey, and now the Endover Hospital is an institution in itself.
We used to do around 50 years back. And the indications for hysterectomy would be myoma, prolapse, abnormal uterine bleeding, malignancy, obstetric hysterectomy, and others. And in all of these, we have to see that what are the conservative options that we have. The problem with drug 2, number one, never ask the barber if you need a haircut. And that is the problem that happens. And we see a lot of people go out learning only 3 surgeries. One is a DNC, one is a cesarean section, and a third one is a hysterectomy. And whenever a patient comes to them, they try to see which of these 3 fit the patient's better. The other question comes again to the root of hysterectomy, and I will talk about that later. That if you have a hammer in your hand, everything in the world looks like a nail. So we need to rise above being a laparoscopic surgeon or a vaginal surgeon or an open surgeon and see what suits the patient best in terms of her particular situation. So we have a lot of alternatives to hysterectomy. For AUD, we have medical management, the LNG IUS, endometrial dilating procedures. step back and get the ladies forward. We similarly have a yoga event coming up where only endoscopies below 40 will operate, and we have an abundant
government job for 20 years. I have been very closely associated with gynecologists because almost 80 to 90% of my patients who were referred to me for ultrasound were gynae patients. So I am actually very privileged to be among such eminent gynecologists today. So I hope endoscopy surgery, I think, because of the recent advances in medicine, is coming up in a big way. And I think every woman has a right to this minimally invasive surgery. And I hope this conference of yours, the various lectures, workshops, interactive seminars, they will help you in enhancing your skills, and you can become even better endoscopic surgeons.
This academic event is being held by the IAGE of Punjab Medical Council. I hope this meeting is going to be a very helpful learning experience for all of us here. I am glad to inform that this CME is accredited with 8 credit hours by Punjab Medical Council. Punjab Medical Council is an autonomous and a statutory body constituted under the Punjab Medical Registration Act 1916 and the Punjab Medical Registration Amendment Act 2010. Punjab Medical Council is vested with powers, duties and function of regulating the practice of modern scientific system of medicine. One main function of the Medical Council is to provide for the registration of all doctors and to maintain an up-to-date register of all medical practitioners of Punjab. The Punjab Medical Council registrations and renewals, they are an important part of the medical practice. In case of any complaint or litigation, it is the registration in PMC that is first and foremost important. Recently, Punjab Medical Council has been adjudged as one of the most doctor-friendly councils among all the medical councils of India.
I am sure that the live surgeries that we saw yesterday and the seminars and the session that we had today will definitely go a long way in enhancing the skills of the young surgeons who are coming up. And of course, as you mentioned, minimally invasive surgical access is definitely the right of every individual, every women. We hope that such activities, such conferences will lead to helping the young surgeons to come out and enhance the skills going forward. I'd like to thank our guest of honor,
all executive members, colleagues and friends. I thank all of you for unanimously nominating me as the founder president of the Punjab chapter of Indian Association of Gynae. I am overwhelmed with the trust placed in me, and I accept this honor with immense humility. It has been my personal belief that for well over a decade and a half, cutting-edge gynae endoscopic surgery is being performed in Punjab and Chandigarh by some of the most gifted surgeons. I congratulate all of you for conceptualizing and bringing to fruition the Punjab chapter of Indian Association of Gynae Endoscopy, which would serve as a platform for advancing gynae endoscopy in this region, and not only that, would make people from Punjab and Chandigarh more visible nationally. Inspiring young gynecologists to embrace gynae endoscopy, seamless exchange of thoughts in tackling complex surgical scenarios and their complications, and strengthening academic related to endoscopy are some of the salient objectives that we hope to accomplish through our meetings, CMEs and workshops. The mantra of true strength we know comes from sincerity, hard work and a team approach. To accomplish this, I am fortunate to have young, vibrant, talented and dedicated team. I would like to conclude by quoting the Father of Nations.
Thank you, Dr. Atul, thank you, Pandit Palaskar sir, and all the members of the IAGE who came and operated and spared the time with us, and also Hidendra ma'am, Vishwadeep sir, and Jasmine ma'am. Thank you so much. We shall now be carrying on with the conference. We shall be divided into the two halls, and we'll start off with the next session. Thank you all the audience for patiently sitting through the inauguration, and thanks for being here with us. मैं डॉक्टर सीवी गिल, मैं co-chairperson ऑर्गेनाइजिंग चेयरपर्सन लुधियाना में ये रीजनल कॉन्फ्रेंस हुई है गायनी एंडोस्कोपी पे। इसमें हम जो लेडीज़ की प्रॉब्लम्स हैं उसके लिए कैसे आप दूरबीन वाली सर्जरी, लैप्रोस्कोपी सर्जरी कर सकते हैं, उसके बारे में हमने डिस्कस किया। कल हमने 13 केस लाइव वर्कशॉप दिखाई ताकि लोग अपनी स्किल्स, अपना हुनर इस चीज़ में एडवांस कर सकें। हमारा एम है कि सबको ये स्किल्स प्रोवाइड हो ताकि लेडीज़ की इम्प्रूवमेंट और लेडीज़ की केयर बेटर हो सके एंड वो घर जल्दी जा सके, उनकी रिकवरी जल्दी हो। ये इसी के साथ हमने पंजाब का पहला जो चैप्टर है हमने लॉन्च किया है और हमारा यही मिशन रहेगा कि हम